Good afternoon and welcome back, everyone. Actually, good morning to some of you in the West. So good morning and good afternoon. We're pleased to have you join us for the final segment of the United Cerebral Palsy 2021 annual meeting. Our keynote address will be by Dr. Neil Lamb. The subject of Dr. Lamb's addresses is a very timely keynote about the impact of the pandemic on the disability community. But before we continue, and with apologies to those who were not with us yesterday, I'm going to just repeat some brief remarks about United Cerebral Palsy and the work we do. For those of you that may not be familiar with our organization, United Cerebral Palsy has 58 affiliates across the United States and Canada that provide disability resources, vital services annually for more than 150 children and adults of all levels and abilities in all stages of life. UCP and its affiliates strive every day to ensure a life of inclusion for persons with disabilities and to be the indispensable resource for individuals with cerebral palsy and other disabilities, their families, and their communities. To learn more about United Cerebral Palsy, please visit our website at ucp.org, where you can also sign up for our quarterly newsletter, Life Without Limits. You can also find us on all major social media platforms. A quick housekeeping note immediately after this presentation, which is expected to last about 45 minutes, our speaker, Dr. Lam, will take audience questions. So feel free to enter your questions anytime by clicking on the chat icon at the bottom of your screen, and we'll make sure it gets to the queue. Here now, and it's my honor to introduce Dr. Lam, is Cheryl Smith, the chair of Southern Region of UCP affiliates and the CEO of UCP Huntsville and Tennessee Valley. Cheryl, I'll leave it in your hands.
Thank you, Armando, and thank you for the opportunity to introduce Dr. Lamb, who in addition to being nationally renowned, also happens to be based in my hometown of Huntsville, Alabama. Members of the UCP South RAC were fortunate to hear a presentation by Dr. Lamb during the peak of the COVID-19 pandemic. He conveyed details about the virus and treatment protocols in an easy to understand manner for even those of us without scientific backgrounds. I'm excited today to introduce this award-winning science communicator to all of you in the UCP family. Dr. Neil Lamb leads the educational outreach team at the HudsonAlpha Institute for Biotechnology in their endeavor to cultivate a more genomically literate society and to inspire and train tomorrow's biotechnology workforce. This past year, more than 1.9 million students, educators, practitioners, and members of the general public were impacted by his team's efforts. Dr. Lamb earned his BS degree in molecular biology from Auburn University and his PhD in genetics and molecular biology from Emory University. Prior to joining HudsonAlpha in 2006, Dr. Lamb was a faculty member in the Department of Human Genetics at Emory University's School of Medicine. While at Emory, his career shifted from hands-on research to science education after realizing that he found his true calling, inspiring a passion for genetics and biotechnology in others. In recognition of his contributions to the advancement of science and education, Dr. Lamb was awarded the 2018 Faraday Science Communicator Award from the National Science Teaching Association. His blogs, Shareable Science by Dr. Neil Lamb, make science easy to understand and enjoyable to explore. I hope you will take a moment later this week to learn more about science and genetics through his video blogs located on the HudsonAlpha website. As a reminder, during Dr. Lamb's presentation, the chat function will be muted. Please direct all questions to the Q&A function. Dr. Lamb will be addressing as many as time allows after his remarks. So once again, thank you, Dr. Lamb, for being with us today. The virtual platform is yours.
Thank you so much, Cheryl, and thank you for that lovely introduction. And thank you also to Armando. I am so honored to be here with you today to talk a little bit about COVID. I'm going to go ahead and share my screen. This is that moment when every speaker holds their breath in the hope that everything actually works. Cheryl, if you'll give me a thumbs up that you can see that. Perfect. Excellent. All right. So again, it's an honor to be with you this afternoon. Here are the things that we're going to cover in our time together. I'm going to talk a little bit about the current status of the SARS-CoV-2 virus and new cases. We'll look back at the historical context. We'll talk a little bit about what we know about the disease and about current treatments that are now available. Then we'll talk about vaccines and the data around vaccines. And then we'll go to variants. And then I'll talk about what are the key questions that we still hope to answer that are outstanding. And then we'll take time for your questions as well. My goal is that this feels not at all like a high school biology class or chemistry class, where you are hiding your head at the overwhelming amount of information and vocabulary, but that this instead feels more like an informal overview and a place for you to get maybe some questions answered. With that, let's start with this picture. For many people around the United States right now, it is spring, but it feels like a time of renewal as we step out of a really long, dark time of the pandemic. And I recognize that in certain parts of the country, as the pandemic continues to behave differently, it may not feel like it's a time of awakening and renewal like you see on the screen. It may feel more like this, that we're just pushing up through the snow of the challenges of COVID and just beginning to anticipate this back to somewhat more normal experience. And I also recognize that for many people here in the United States and certainly around the world, it is still deep in the dark winter of the pandemic, with infection rates continuing to climb in some parts of the world. I also want to acknowledge that for many people who might even be joining us on this Zoom, the pandemic has been a time of great challenge for you or for those that you care about or for those that you serve. You may have lost loved ones or colleagues. You may yourself have struggled with COVID-19. So at the same time that we talk about this beginning to emerge from the pandemic, I want to acknowledge that that's not necessarily the case for everyone. And I don't want to look like I'm glossing over the challenge and the tragedy of what we have encountered. I also just want to say how impressed I was with this most recent case for inclusion report. I read it over the weekend, and I thought that UCP did such a fantastic job of highlighting the challenges that the pandemic brought to the community of disability services, but also was able to shine a light on those groups that have gone over and beyond and have found ways to continue to provide service. It was just such a wonderful, I guess, touch point for me to say, hey, these are huge challenges. We have opportunities to resolve these. Here's how we can do that. And then to acknowledge the work of all the folks in the different disability communities. So well done to all the groups that put this together and contributed to this. All right, let's start with a little bit of overview. Let's talk about the risk level of COVID-19 at the county level across the United States. Now, if you are still relatively new to Zoom, you should be able to take whatever piece of the window has the pictures of maybe me or of us, and you should be able to drag and move it around the screen if it's covering up something that you specifically want to see. So just that housekeeping tool. But this is data that from a group called COVID Act Now that looks at every day what are the indicators of how the pandemic is progressing or regressing across the country. And they measure risk level by three things: the daily number of new cases, the infection rate, so how rapidly is the virus replicating through a community, and the test positivity, so how many of the COVID tests that are being given out in a community are actually coming back positive for the virus. This is the data as of yesterday, and I'm just thrilled to see how little red there is across the country and how much green we're actually seeing. So we are at lower risk. Now, certainly there are some counties and some communities that are increasing in risk, but we are seeing in America a really rapid drop in the number of cases. You can see that here. There are lots of different trackers. This is one of the ones that I follow. This is from the New York Times. The top graph shows you since the beginning of the pandemic, the 7-day rolling average, that's the dark red line, of the number of new cases identified around the country every day. And you can see last March, April, that initial climb, and then we leveled off for the first part of the summer, and then we rose in July and August, and then dropped off a little bit in the fall. And then you can see that huge mountain from the fall and into the early winter, and then the sharp drop off, the plateau, that little bump around the end of March and the first part of April, and then we're continuing to drop down. And then the 3 gray graphs show you the number of tests that have been made available, and the number of people that have been hospitalized, and the number of deaths. And in all those cases, we are really seeing positive data. We are seeing the number of cases approach 30,000, number of new cases around the country, which is a number we haven't seen since last summer. We're seeing drops in the number of hospitalizations and deaths. So around the country, we're really seeing this continued drop in the spread of the pandemic. Here's another way to think about this. This is actually showing you the number of new cases per million individuals. So the brown line, and maybe it's even more dark red, is the United States graph. And I'm comparing that against 2 countries that we are often being measured against right now. That's Israel in green and the United Kingdom in that pink color. And we're being compared against those 2 colors, those 2 countries, because they've reached 60+% of their population being vaccinated, and they've dropped the number of cases. So Israel is now averaging 3 new cases per million people a day. And the United Kingdom, about 10 times that, 33 new cases per million people. We're 3 times more above that, 100. But there are a number of people that believe as we continue to get vaccines, as we cross maybe another 20 million people vaccinated, that we're going to see those numbers drop really drastically, and maybe all the way down to 1 person per 100,000 individuals. That would really begin to get us to the level of containment of the SARS-CoV-2 virus. We've still got a ways to go, but that's what I think a lot of people are watching and keeping their eye on over what happens over the next several weeks. Now, let me shift gears. This is something that you probably are familiar with, and because we've all been living with the news around COVID for now 15 months, I'm going to hit this only lightly. But if you are infected, and if you have serious symptoms, recognizing that some people are asymptomatic and never even know that they're infected, but if you have symptoms, not only do they impact your lungs, your upper respiratory system, but a whole host of other parts of the body, from your brain with strokes and seizures, blood clots and problems with your vessels, the well-documented loss of taste and smell, but also damage to your kidneys and your liver and other parts of the body. So this is a virus. One of the great unknown questions is how does this virus cause such a wide range of symptoms? Some people who don't even know that they're infected, and some people who actually find themselves seriously ill in the hospital or even pass away. We'll talk a little bit about what the science might be hinting at, but this is really one of the great unknown, unanswered questions still around COVID. And then in addition to the acute phase when people are first infected, we've also got issues around COVID that show up later after the initial infection. So that's the concept of long COVID, which is individuals that continue to deal with symptoms from the infection weeks and in some cases months after they were initially infected. And you can see the graph on the left-hand side from the CDC that almost 3/4 of the people that have been hospitalized with COVID had at least one of these ongoing symptoms 6 months after their acute illness. So this is more than, I'm just tired, I just don't feel good. These are serious impacts that in many cases prevent individuals from being able to work. And trying to understand what is it that causes long COVID is another one of those questions, because you are potentially thinking about millions and millions of Americans that are going to be dealing with these lingering issues long after the virus is gone from their body, or at least measurable virus is gone from their body. And then on the right-hand side, this is a pediatric disorder, multi-system inflammatory syndrome in children, MIS-C. And this occurs weeks after a child has had COVID-19, and they might have even been asymptomatic. They weren't even aware that they had COVID-19 in some cases. And then there is an inflammatory response across multiple organs. And this often lands them in the hospital with unexplained fevers and with organ damage. This is another one of those pieces that we don't really understand why some kids are targeted for MIS-C and most kids completely escape it. We know that in general, pediatric populations are less likely to be infected and less likely to have serious illness. That doesn't mean that there aren't kids who are hospitalized, but that's at a much lower risk than with adults. But this MIS-C is still a bit of a question mark. Now let me talk a little bit about what seems to put us at a higher risk of that serious illness. So do we have some hints about why some individuals, if they get infected, might have a more difficult time, might have a greater chance of having more severe symptoms or finding themselves in the hospital? This is data that comes straight from the CDC, and I would refer you to this link at the bottom because they do a really nice job of saying, here's the evidence, here's the published evidence for each one of these medical conditions that shows that there's a higher risk of serious illness. And you can see it runs the gamut from cancer to dementia to an immunocompromised state, maybe because you're on immunosuppressant drugs or you had an organ transplant, sickle cell anemia, stroke. These all put adults at a higher risk of more serious illness. And so these are called comorbidities. These are things that if you have 3 or 4 or 5 of these and you get infected, you're at a much greater risk. Now with children, the data is less clear. There are certain underlying medical conditions that do put kids at an increased risk, but exactly which one of those conditions, the evidence is still kind of scant around. This is what the CDC says: medical complexity with genetic, neurologic, metabolic conditions, or congenital heart disease. So this is kind of a really broad brushstroke of children that have these comorbidities, these challenges. And certainly disabilities, developmental and intellectual disabilities fall into this category, as well as children that have the same kind of comorbidities that you often see problematic with adults, like obesity and diabetes and asthma, chronic lung disease, anything that makes breathing a potential challenge. Now, that said, I did some deeper looking because there weren't a lot of specific disabilities on these lists. So I started digging through the literature, and there's not an enormous amount of data out there. I found a relatively recent paper that talked about why individuals with cerebral palsy might be at a higher risk for COVID-19 because of some innate respiratory issues. I also found some data that said that individuals with disability were thought to be at a higher risk, but the data didn't bear that out. And then I have this paper that you see in the very center of your screen, the devastating impact of COVID-19 on individuals with intellectual disabilities in the United States. This paper came out in March and looked back at 68 million patients across healthcare organizations, looking specifically among those patients at which ones had intellectual disabilities and what were the outcomes. And the data are pretty striking and very sobering. And you can see that summarized on the left-hand side of the screen. Compared to the general population, those in this study with intellectual disabilities were 2.5 more times likely to contract COVID-19. So they were 2.5 more times likely to become infected. They were 2.7 times more likely to need to be admitted to the hospital, and they were almost 6 times more likely to die from the infection than the general population. And the authors of this study say that intellectual disability is the second highest risk factor for poor outcome, second only to increasing age. And they attempt to tease some of this apart They note that patients with intellectual disability may have a lower ability to comply with strategies that reduce the risk of infection, masking and distancing. For example, they may require daily care with multiple individuals coming into their space, or they're in close proximity with other groups where masking and social distancing may be challenging for them. They also note that often individuals with intellectual disability have a cascade of other associated disorders. And many of those are things that are on those comorbidity lists that we saw a couple of slides ago. So it's difficult to tease out how much of this is specific to any one individual disability and how much of it is kind of the mingled impact. The other papers that I found reiterated what was in the UCP case for impact, the 2021 case for impact, that the pandemic cut many individuals off from their ability to have daily necessary care, or they were challenged for their routine medical care, except in the instances of telehealth. So the collateral damage from the pandemic for individuals with disability is also high, whether they ever developed COVID-19 or not. Let me shift gears a second. Let's talk about treatment options. We haven't heard a lot about treatment recently because it's been kind of swamped by the news about vaccine. I want you to pay attention to the top part of this image. I'll show you the bottom part in just a second. COVID-19 infections actually follow two different phases. The first phase is when the virus is rapidly replicating inside your cells, especially in your respiratory system. And that leads to many of the symptoms, the fever, the coughing, the fatigue, as your body fights the virus, as it calls your immune system to action. For most people, the infection resolves, the immune system does its job. But for some individuals, the immune system over-responds. There's a hyperimmune response. And that's what often lands people in the hospital, requiring supplemental oxygen or finding themselves in the ICU, this overwhelming inflammatory phase. So as we think about treatments both for the viral phase to slow the spread of the virus, and for those individuals that have now moved into the inflammatory phase, how you tamp down the immune system. And here's a set of therapies that have been vetted, have gone through clinical trials, or have been through some clinical trials and have some data. So anything that's got a dotted line around it, there's conflicting data. There's enough to say we need to keep exploring this, but there also is some data that says this might not be as effective as we would hope. So I'm just going to start at the very top with monoclonal antibodies and remdesivir. These are specifically designed to, monoclonal antibodies bind to the outside of the virus. They bind to the spike proteins. Here we go. So if this is the outside of the SARS-CoV-2, and these are the spike proteins that connect to human cells, monoclonal antibodies glom on to this, and they prevent it from binding to human cells and gaining entry. And they also flag the immune system that something is going on and that this needs to be destroyed. So there's been really impressive success. Monoclonal antibodies have been approved for emergency use by Eli Lilly and by Regeneron. They're often used relatively early in infection. That seems to be when they're most effective. Remdesivir is a medication that's used a little bit later. It's an antiviral that also slows the ability of the virus to replicate and spread. And it also was actually one of our earliest treatments that was shown through clinical trials to be effective. Then you've got convalescent plasma, which is right beneath it. And that's a little bit like monoclonal antibodies, but that's taking the blood of an individual that has recovered from COVID-19 and their body is still making antibodies, and you take that plasma and you give it to somebody that's early in their infection. The data is a little shaky around this. There are some studies that show that this is effective and some studies that don't. And it looks like the difference is that there's a lot of variation in the strength of the antibodies from one person to another who provides convalescent plasma. So you really want to try to narrow that down and identify who's got the best plasma that's chock-a-block full of these antibodies to be able to fight the virus. And then you've got, if I'm staying on that second row, corticosteroids. These have been incredibly valuable in tamping down that overactive immune response. And the best part about that is like dexamethasone is really, it reduces the length of time somebody is in the hospital and reduces the likelihood of serious side effects and fatality, but it is incredibly inexpensive. That's a beautiful combination, something that works, but doesn't cost an arm and a leg. And then on this last line, we've got vitamins and minerals. There's been a lot of discussion around zinc and vitamin D and vitamin C, and the data is still out on that. Large scale clinical trials, in some cases have found some benefit, and in other cases they haven't. Vitamin D seems to has the strongest level of evidence, not so much for zinc and vitamin C. But again, those data are still being gathered. And then blood thinners, because we know that individuals with COVID-19 sometimes develop clots. And so if you give them blood thinners, will that actually help reduce that incidence of clotting and strokes and tissue damage? And then there's a tocilizumab, which I probably just totally mispronounced, but that's another anti-inflammatory that again helps tamp down the immune system. So compared to where we were a year ago, we have a toolbox of therapeutic options. They aren't as many as we would perhaps like, but we have the ability now to try to reduce the likelihood that someone goes into the hospital. And if they are in the hospital, that reduces the likelihood that they find themselves on a ventilator. And so I'd say that's really positive news that's come out of this work. And now I'm going to shift and specifically focus on vaccines. So vaccines don't focus on treatment, they focus on prevention because they are designed to be given before someone is exposed to the virus. And the body says, hey, I don't recognize this. This is different, and builds an immune response against it. So that when you do encounter the virus later on, your body goes, oh yeah, I've seen you before. I know exactly how to defend against you, and it prevents you from getting really ill. So there are 12 vaccines around the world that have been approved for emergency use or given full approval by at least one country. Here in the United States, there are 3 vaccines that have received emergency use authorization by the FDA. And you know these. This is the Pfizer BioNTech and Moderna, and then the Johnson & Johnson. The first 2 are messenger RNA vaccines. They insert into your cells a small piece of messenger RNA genetic instruction that tells your cells how to make those spike proteins. And then those spike proteins end up on the outside of some of your cells that have taken up the vaccine, and it triggers the immune system to build that immune response. Johnson & Johnson's a little bit different. It uses a modified cold virus that's been modified so it can infect your cells, but it can't reproduce itself. And it provides a piece of instruction that again tells your body how to make the spike protein. You can see here the ages of authorization. Last week, the Food and Drug Administration approved the Pfizer vaccine for individuals as young as 12. Moderna and Johnson & Johnson are 18 and above. The mRNA vaccines are 2 doses. The Johnson & Johnson is 1. And then I'm showing you the efficacy in the clinical trial data. The mRNA vaccines showed really high efficacy, like 94, 95% effective at reducing serious illness from COVID-19. Johnson & Johnson had a slightly lower level, 72%, but it was 85% effective against people being hospitalized and severe COVID. And again, it's difficult not to make direct comparisons between these 3, but these clinical trials use slightly different endpoints. They were at slightly different time points in what the virus was doing around the country. Johnson & Johnson's a single dose, and that doesn't require refrigeration. And that's a huge benefit for a lot of people. And again, all 3 of them do a good job of keeping people sick and out of the hospital. So with that data, with those 3 vaccines in the United States, where are we? So this is data that was posted yesterday morning. So I don't have the most recent day of data, but you can see that we've had in this red box, 157 million Americans that have gotten at least 1 dose, and 122 million Americans that have now been fully vaccinated. So 47% of the total American population has received at least 1 dose. Almost 60% of the population 18 and above has received at least 1 dose. almost 60% of adults, and 85% of our senior citizens has received at least one dose of the vaccine. This is incredible that we have been able to mass vaccinate this many people this quickly. But 47% of people that have received at least one dose means you still have 63% that have received no dose. Some of that are individuals that are vaccine hesitant, that don't want to get a vaccine. Some of that are individuals that haven't been able to take the time off or have access to a vaccine near them. Vaccines are now available across the United States for anybody 12 and above, but I recognize there are still some hurdles to getting more of those vaccines in arms. This shows you a map from the CDC of the number of vaccines given per 100,000 individuals. I'm in the state of Alabama, and I think our most recent number was somewhere around 39,000 vaccines per 100,000 individuals. So we're kind of near the back of the pack. Other states that are darker blue are doing a better job of getting more people vaccinated. And then if you look at the makeup of those vaccines, you'll see that there are slightly more individuals that have received Pfizer versus the Moderna vaccine. And then there's about 9.5 million people that have received the Johnson & Johnson vaccine. So we are continuing to get more people vaccinated. And the goal is to get as many of those vaccines to as many people as possible to slow the spread, to make it more difficult for the virus to find somebody new to infect. You can look at the demographics of the vaccine across the country. So this is showing you by age. The darker red shows you since the vaccine was first available at the end of December through, I think this is through yesterday. The pink color shows you the demographics of people that have started vaccination just in the last 14 days. So the most recent group. So you can see that we're getting, understandably, more and more younger people in the last couple of weeks than we had been historically, as we have now opened vaccine up to more and more people. You can see the same thing when you look at race and ethnicity. And you can see that the majority of the individuals, so more than 65% of vaccines have gone to individuals that are Caucasian. We are seeing over the last several weeks some shifts in increasing our numbers of our underrepresented populations, of our Hispanic and our Black and our Native American populations. We still have a ways to go to get vaccines into all of these different populations. And I recognize vaccine hesitancy is an issue. There's a lot of misinformation. When you have a pandemic, the infectious agent isn't the only thing that spreads virally. Misinformation spreads as well. And there are as many myths and complete outright incorrect statements out there that clinicians and scientists and educators continually have to try to counter. Misinformation spreads better than the correct information, which I, as a science communicator, find incredibly frustrating. Okay, let me show you 3 pieces of data that actually now go beyond the clinical trials and talk about vaccine effectiveness in the real world. So this is saying, okay, now that we start putting vaccines into millions of people, not just the 30 or 40 or 50,000 in the clinical trials, what do we find? So this is a paper that came out on the 15th of May, so just a couple of days ago, in the Lancet, looking at cases in Israel. And Israel primarily used the Pfizer vaccine. And they found that people that were vaccinated had that the rate of infection with the virus was reduced by 95%. And the rate of asymptomatic infection, because they continually tested these individuals on a repeated basis to uncover asymptomatic infections, that was reduced 92%. And severe illness, hospitalization, and death all were reduced by about 97%. So this is actually even better than the clinical trial data, because the clinical trial data told us that the vaccine reduced the incidence of severe illness. It didn't tell us anything about asymptomatic or about the risk of infection. We thought vaccines would reduce transmission, but that's not what they were tested for. So this actually tells us that the vaccine not only reduces the severity if you do get infected, but it actually does a really good job of preventing infection in the first place. Now, there are still people that get infected and develop symptoms. Those are breakthrough cases. You probably saw that with the Yankees, that set of individuals on the Yankees ball team. Those were breakthrough cases. But breakthrough cases in general are much milder. They're asymptomatic or they're very mild compared to what you would find in an unvaccinated population. Here's another study. This was actually published just within the last week by the Centers for Disease Control, looking at healthcare workers in the United States who received either Pfizer or Moderna. And they found that symptomatic infection was reduced 94%, which is right in line with what they found with clinical trials. And they had released an earlier study a few weeks ago that also found that infection was reduced as well. And then this is a preprint that actually was released, I think on Sunday afternoon, maybe it was over Saturday. It hasn't gone for peer review yet, so you want to take this with a grain of salt, but this is specifically looking at the Johnson & Johnson vaccine. And they found that it reduced symptomatic infection by 77%. And again, that's in line with what you saw in the clinical trials. And the benefit of the Johnson & Johnson vaccine is it's one dose. It doesn't have to be kept at really cold temperatures. It's easier to distribute. Now, you might know that there was a big concern in February and March about the Johnson & Johnson vaccine right after it was given emergency use authorization. There were a handful of cases, primarily in women, of a very rare blood clotting disorder, a clot form in the brain and forming in other parts of the body, and a lack of platelets. So there were 6 women that were identified, 1 who passed away, and the FDA put a pause on vaccination while they gathered more data and reviewed it. And then about 10 days later, they said, we think that this is incredibly rare. Here's what our data are telling us, that the frequency is 1 in 500,000 to 1 in 5 million, depending on if you're a male or a female in your age group. So we're going to restart vaccination. So they just revisited this data last week. Out of 9 million vaccines that had been given up to the point where they looked at this data, there were 28 cases of this rare clotting that were identified. And I don't mean to minimize the impact of these 28 cases, but I want you to put that in context, 28 out of 9 million. And the risks were greatest in women who were under the age of 50. So one of the potential recommendations is that women under the age of 50 might think about a different vaccine, maybe Moderna or Pfizer, but women over the age of 50 and men who are really attracted to the fact that this is a one-shot vaccine, the risk of this is incredibly small. It's small for all individuals, but it's even smaller for older women and for men. And that brings up a great point about vaccine safety. The data that we have, vaccines have one of the highest bars that they have to clear in order to get approval. And there's a system set up where when someone is given a vaccine, they have the option to be followed with daily and weekly questionnaires. If there are serious side effects that happen, or if there's death that happens, healthcare providers are required to submit this to a database. So far, out of the 156 million vaccines, there are somewhere in the neighborhood of 4,500 deaths. Now, let me be real clear. These are people who got the vaccine, and at some point after that, these people passed away. That is not the same as these people passed away from the vaccine. So the Centers for Disease Control and the FDA look through all these data. They look at death certificates. They talk to physicians to determine if there's any connection, if there's any link between vaccination and what these individuals have died from. And aside from this rare clotting disorder that we just talked about, there is no evidence among those 4,500 individuals that passed away that it was because of the vaccine, that was what the cause was. That doesn't mean that people don't try to make a story out of that. You've seen that on news. You've seen that on social media. But I want to be real clear. Those are associations. These people got the vaccine. These people died. That's not the same as these people died because they got the vaccine. You've got to tease that apart. And so far, we don't see any of that evidence. Okay, let me bring us in the home stretch. Let me begin to wrap us up so we can take time for questions. Let's talk about the variants. And I love this cartoon from speedbump.com about these, in this case, they're bacteria, saying, Ooh, our kid's a special, powerful, more powerful kind of variant. They tell us that every single time. It's that keeping up with the Joneses. In this instance, a DNA variant means that there is a change in the genetic code of the virus. And viruses evolve. They change their genetic code randomly over time. That's how all viruses work. The key is that sometimes those random changes, by luck, make the virus work a little bit more effectively. It can infect cells better, or it can evade the immune system. Most of the time, that's not what happens. But when you've got millions and millions of people around the world being infected with this virus, the likelihood that you're going to develop new mutations that could be problematic is pretty high. And that's exactly what we've been seeing over the last several months as you hear a lot of conversation about variants. Most of these variants are not things that you need to worry about. There's a handful that are variants of concern that we monitor more closely. This is the probably leading one right now. It's called B.1.1.7. You probably know it as the UK variant because that's where it was first identified. This specific version of the virus, every single one of these lines that you see here represents a place in the genetic code that is different from what we'll call classic SARS-CoV-2. And a handful of these specific changes are thought to make this version 40 to 60% more transmissible, so more easy to spread from person to person. And there's some evidence that it may be more severe, although that evidence is a little soft right now, but I put it in here just as a possibility. Vaccines are fully effective against this variant. So a person who's vaccinated who is exposed to this variant has the same protection as if you were exposed to the classic SARS-CoV-2. But this more transmissible is important. And let me show you this on the next graph. There's a lot of numbers here, a lot of information. I just want you to focus on broad themes. So each one of these columns is showing you a different 2-week window since mid-January. And each color in that column is showing you a different variant of the SARS-CoV-2 virus. The ones that are light and dark blue are ones that are much more classic. They aren't variants of concern. It's the yellow, gold, orange, and the purple that are these new variants that we're seeing. And I want you to pay most attention to that tan color, the B.1.1.7. That's the UK variant. And what you can see is in the United States, when it was on the 30th of January, all the way on the left-hand side of the screen, that was a tiny little box. It was not very prevalent at all. But we knew to watch for it because in January, it was hugely driving infections in the United Kingdom. So we knew to begin to track it. And you can see over this year, it has become a larger and larger and larger portion of that bar graph. It now accounts for somewhere between 60 and 80% of the variants that are classified across the United States. So it is the driving variant, the most common variant right now in the United States. You can see that the California variants, which are those darker, those orange colors, those have actually gotten less and less frequent. They increase and then they've gotten less. The Brazilian variant, the P1, has actually started to increase. We're going to have to watch that because vaccines are slightly less effective against P1. We're going to have to see if that continues to spread in the United States. And then you've got the New York variants, which really raised a lot of concern because they were seen at high frequency in the Northeast, but they also don't seem to be major issues that we need to be concerned about. And you can look at this graph that shows you around the country, the specific frequencies. Again, pretty much everywhere in the country, the variant from the UK, first identified in the UK, is the driver, but you've got different frequencies of the other variants, depending on what part of the country that you look at. Here's the bonus, or here's the happy part of this story, that even against all of the variants that have been identified, our vaccines are still effective. They may be slightly less effective, but there's a buffer built into the vaccine. So even if it's less effective at neutralizing the virus, it still is effective enough that it can slow the spread and prevent illness. That doesn't mean that everybody who gets vaccinated, again, is 100% protected. There are breakthrough cases, but the variants, the vaccines that are available in the United States and some of the vaccines that are available around the world, either in lab studies or in actual real world data, have been shown to still be effective. So we want to pay attention to the variants, but we don't want to be terrified by them, because at this point, we don't have a variant that the vaccines can't put on hold. That's the really good news that I think comes out of this. Okay, last set of slides. Here are questions that I'm frequently asked, some of which we have the answers to and some of which we don't. When will the vaccine approval be extended to children? So last week you saw it extended to 12 to 15-year-olds for Pfizer. Probably sometime this fall, you'll see vaccines become available for children. There's a different potential set of dosage. There's some additional questions that you want to ask. Children have a lower risk of spreading, of getting infected and of spreading the virus. So there's a different question that I think parents ask themselves when you're looking at vaccinating children than when you're vaccinating teenagers or adults. I'm not saying that you wouldn't vaccinate children, but the decision point, the data point varies or differs depending on the age group of the person that you're looking at. How long will immunity last? At least 8 months. That's what we know from people that were part of clinical trials last year. So we've been following them for at least 8 months and we still see immunity. We actually think it will probably extend out beyond that, 12 months or maybe even more. We'll know when we've reached the end because we'll see lots of folks from the clinical trials now lose immunity. And we'll have a heads up on that, a several month heads up on that, to begin thinking about, are we going to need booster shots to boost our immunity? Right now, it's too soon to tell. It's possible that we will need booster shots. It may be that it's a third dose of the same vaccine that you were originally given. It may be that it is a booster that's slightly different from the vaccine you were originally given. We just don't yet know. I do know that it's much faster, at least for the mRNA vaccines, to make a booster. So you can get that to market in just a matter of weeks. Why does the disease range from asymptomatic to fatal? That is one of those huge unanswered questions. In some instances, it may seem to be that our own immune system functions differently from person to person. Some people's immune system responds very quickly. Some people's immune system is a little more slow. Some people's immune system responds weak. Some people's immune system responds really strong. So some of that might be our own internal difference. Some of it might be the amount of virus that we're exposed to that actually causes problems. And then what causes long COVID? That's an incredibly valuable question that we're going to want to know that we just don't have the answer to. All right, next to the last slide. I put together, as Cheryl mentioned, a series of videos. These are 5 to 10 minute videos that cover a whole lot of background content. Side effects of the vaccine, the variants, how you measure risk. I know we're now moving to the end of the pandemic as a huge national shutdown kind of piece. We're still going to have COVID-19 living with us for quite a while, but it will be something that I think we're going to be able to manage, provided that we don't find a variant that now completely evades all of the immunity that you have, either because you've been vaccinated or because you've had COVID and you recovered. That's the worst case scenario. And I'm not saying that's where we're going, but it's something that we've got to watch. But in general, we're coming to the end of this phase. That said, there's a whole lot of content here. If you have questions about COVID-19 or vaccines or treatments, you might find something here that would be useful for you. And with that, I'm actually going to now stop. I'm going to thank you for your time and your attention, especially on a Tuesday afternoon at the end of your meeting. I'm really honored to get to talk to you about COVID and about where we are and about the positive prospects of what's coming down the pike. I'm going to stop sharing my screen, and then Cheryl, I think we're going to answer a few questions.
Yes, thank you very much for a very informative walk through a very complex conversation. Let me turn my camera back on. Very complex information that you made easier to understand. And even with that, I know we have a number of questions. Joy first asked if you would share the citation on the study about COVID and the respiratory complications related to CP?
Yes, I actually will. I'm going to pull that up and I'll put it in the chat. So I apologize. You're not going to watch me work my way through my slides. But here we go. Okay, so I'm going to put it in the chat. I think I can do this so that everyone, panelists and attendees. Okay, why?
I believe we'll also be sending out some information later, so we can include it with any materials we send out.
Yes, and that would be much better than the awkward silence as everyone waits for me to type this in the chat. All right, let me do this last piece and then we'll move on to the next question. It is the Journal of Pediatric Rehabilitation. 2020. All right, there we go.
Great. And the reason I asked that first is that Michael mentioned that he was vaccinated, and he said it was questionable whether CP is classified as a high risk. We know that a lot of our population does have concerns with the lung and other issues. So could you please elaborate on CP being a high risk or not?
Yes, I ran into this same challenge, Michael. I could not find in the CDC data mention of CP as high risk. And that's why I actually went back to the medical literature. And there was very little in the medical literature that gave me any indication that CP truly was high risk. This one article was the only thing that I found. So I unfortunately don't have a lot of good answer around that. The CDC, at least from what they've done, doesn't necessarily consider it high risk. Now, if there are, I think it might also depend on the constellation of features for an individual with CP, that in some cases, there may be additional symptoms that would move you into that high risk category because you would fit in one of those other buckets. But I didn't see a lot of data that called out CP specifically as a high risk feature.
And following that up, someone has heard people say that they're autoimmune or they're immune deficient, and they then were hesitant to get the vaccination. Should they worry?
The initial data when the vaccines first came out was that individuals that had suppressed immune systems should have a conversation with their immunologist about whether they should be vaccinated, because these people were generally not included in the clinical trials and there wasn't a lot of data. What I've seen since then suggests that people that are immunosuppressive, that are on immunosuppressive drugs, that have had a bone marrow transplant, there don't seem to be a higher risk of side effects for these individuals in getting vaccinated, but they often have a weaker immune response to the vaccine. And that's not surprising because you have a suppressed immune system. So the vaccine may be less protective for them than for somebody that has a typical immune system and an immune response.
And do you have information about Sinopharma vaccine and how effective that is?
I don't. I'm aware of it, but I have not really looked at their data to have any good answers about what their clinical trial results looked like.
Another question, if you have a family member, a loved one who's hesitant to get vaccinated based on misinformation, how do you recommend we approach them?
This is a really fantastic question. There are lots of reasons why people are vaccine hesitant. And And for many of them, those are very valid. I try to honor why they feel that way. I try never to start with, that is the worst thing I have ever heard, or you're just listening to XYZ, blah, 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 blah. I try to find out what it is that gives them hesitation. Is it something that they've read? Is it that they don't know anybody who's been sick from COVID-19, and so they don't feel that there's a reason to take a vaccine? Is it that they're concerned because they feel that the vaccines were rushed? The research, the science, the safety was not rushed. The red tape was cut, not corners. So I just try to find what is their concern, and then can I point them towards data that may give them the answers that they're looking for? Can I talk to them about those 4,500 deaths from people who've been vaccinated and explain what that is and what that isn't? If they're concerned about things that they've read online about fertility, can I point them to answers about that from trusted sources? So I think it's really having conversation about why they feel that way, and where possible, pointing them towards other information. You're going to have some individuals that you're not going to be able to change their mind. And in fact, you might make them dig their heels in even deeper. So you want to step into some of those conversations gently.
Well, what do you consider the most reliable source or sources to stay regularly and accurately updated about COVID-19 and the vaccinations?
So I spend a lot of time at a website called STAT, S-T-A-T News. STAT News frequently gives updates of what is going on. I also look at the CDC website, the Lancet, the New England Journal of Medicine, and then I'm a Twitter follower. I get some of my content from Twitter. And so there's a handful of people on Twitter that I follow, people like Eric Topol, T-O-P-O-L, and Lindsay Marr, M-A-R-R. Those are folks that I trust their science. They don't try to oversimplify things. And then the other thing that I do is I try to look at getting my news from multiple different sources. So you'll find me at Fox News and at the New York Times, looking at how each group tells those stories. Sometimes it's like they aren't even talking, it's like they're not even talking about the same data, even when they are, but trying to get a breadth of content and get out of my echo chamber.
Very good. Well, Michelle wanted to know if you're finding that people who have contracted COVID-19, are they having more side effects when later getting the vaccines, especially the 2-shot series?
Cheryl, would you say that? Oh, here we go. I see it. Are you finding people who have contracted COVID-19?
I believe some people feel like there's a stronger reaction to the shot if they've already had.
Yes. Thank you for that clarification. Yes, I do. People that have had COVID-19 and have recovered already have a partially primed immune response. It varies. There's a huge range of what your immune response looks like when you've recovered, especially if you were asymptomatic or had really mild symptoms, you might have only a mild response, but that's kind of the equivalent of getting your first dose. And so then when you go to get your first vaccine dose, your body's like, oh, wait, I've seen this before, and mounts a stronger response, which is why sometimes people have more serious side effects with their first dose and with their second dose. It just means that their immune system is really prepped and primed. There's a body of evidence out there that is growing that says that it may be that people who have had COVID-19 and recovered, at some point, the decision may be made that they only need to have 1 dose, not 2 doses, if it's a 2-dose system. They haven't made that decision, and they may not make that decision, but that's kind of the science behind that. If I've already had COVID and recovered, maybe I only need 1 dose in order to serve as my booster.
Great. Could you talk more about people who fall into the following categories at once? Low income, people of color, and people with disabilities. Are healthcare officials paying attention to their needs?
Are healthcare officials paying attention to their needs? So certainly in some cases, these categories, the risks accumulate the more of these categories that you fall into. And individuals that are some of our most vulnerable populations, they're frontline workers, they don't have access to health, to regular routine health care. They may have comorbidities like disabilities or diabetes or obesity or cardiovascular disorders. They are at some of the highest risk of serious side effects if they were to get COVID-19, which is why there was a lot of discussion early on about moving these people to the front of the line for prioritization for vaccination. I think it's really important to make sure that these individuals have access to vaccines, because that is one of the best ways to keep them from falling into these high risk categories. But that means when you're thinking about going to a vaccination station, you've got to be able to take into account access and the ability for people with disabilities to get there. If these are frontline workers, you need to be able to work around their schedule. They may need transportation. So I think all of these pieces become really important when you move beyond the people that are internet savvy and have their own transportation and work a job where they can easily take off and go get vaccinated. So as we try to reach some of the more challenging populations now, we've got to take into account what their specific issues are and how we overcome those challenges.
And then as an obviously affected science communicator, how do you think the government, local, state, and national, get the word out about why it's vital to get vaccinated?
There's not one message that's going to work for everybody. I think we need to do a better job of thinking about how we target our messages based on what people's concerns are, what their situation is. I think we've done a better job of that. I think historically, using the words Operation Warp Speed is one of the worst things we could have done, because it implied for people that we were pushing ahead so fast that we were ignoring boundaries and concerns and that we were cutting corners, when that was not the case. So I think there's some work on the front end that we need to be. I really hope I'm not around the next time we have a pandemic. We will have another pandemic. We see them every so often, but I hope that there are some really great lessons learned in how we communicate issues. And the fact that we've politicized the virus, the origin of the virus, masking, and vaccination. And the fact that we've now politicized that, we've polarized people into one camp or the other. And if you believe this, well, then you certainly can't believe that. And if I believe this and you believe something else, then you are the enemy. We've got to find a better way to communicate science and disagree about things without vilifying each other.
And I think Huntsville does a good job of picking leaders in our community that might represent different audiences to do public service announcements. Maybe they've gone through the COVID themselves and can share their stories. So I think that is helping us to reach certain populations. But I agree with you that if we can't get to them or make it easier for them to have access, that's part of the question, in addition to the misinformation.
That's a great point, Cheryl. One of the most effective ways to communicate about vaccination or about anything else is people that I know and that I trust in my community, people that I've already got a relationship with, people like me. When I see other people like me or people that I know talking about this, I am more inclined to trust the data than when it's coming from somebody that I've never met before, or even a celebrity.
Okay. And then we have two questions about variants. What do you believe is the likelihood that a serious variant may surface in the fall or winter and be resistant to the current vaccines?
That is, I think, one of the great question marks, and one of the things that people are concerned about. It's why it is so important that you get people vaccinated now, so that you make it harder for the virus to infect someone and undergo one of these mutations that then makes it resistant. I think it is within the realm of possibility I think the more people we vaccinate, the less it becomes within the realm of probability. But I would not rule it out. I mean, it is the kind of nightmare scenario that makes for great television.
Okay, and then a specific question about the Indian variant. Have the genetic codes of these been deciphered?
Yes. So the sequence of the variants, the Indian variants, the variants identified in India, let me say it that way, have been sequenced, and they have been on the surveillance groups around the world are tracking those. We have not seen that at any kind of significant frequency here in the United States. The most recent data that I've seen suggests that those variants are at a higher transmissibility. They're more easily spread, and there may be some reduction in efficacy in terms of the vaccines. But again, the buffer is still there that those vaccines still do their job.
Okay, and then Roger, let me see if I can find where it's to everyone. Roger asked a little bit more about your blog series, so I'm going to paste that so you don't have to.
I actually just did.
Oh,
I
did
think
you?
I just did. Yeah,
Okay.
make sure that you can see that.
I was looking for it while you were talking. How in the world you did that both? Okay. Is there any information or link to research being done specifically regarding individuals with disabilities of all kinds, COVID exposure, and vaccines, or is the majority of the research and data correlated by age? Agree with you about the red tape analogy, by the way.
Thanks, James. I haven't seen any specific data looking at all disability. But what I am seeing is I'm seeing groups that are going back retrospectively and digging through medical records and participants in large scale studies, and then trying to parse out the data based on a number of different features: age, gender, ethnicity, comorbidities, specific disabilities. I think we're going to see more of that in the months ahead as we get larger and larger databases and people work together to share that kind of information.
And just to remind everyone, we have only a few questions left, and we do have Dr. Lamb willing to answer questions. Please put those in the question and answer function of the Zoom, and we'll be glad to answer those as we do still have a little bit of time. How specific is COVID PCR in indicating COVID-19 infection?
The PCR tests that we've been using to detect the presence of the SARS-CoV-2 virus, those are really sensitive. They are quite effective. In fact, sometimes they are too sensitive because they may detect low levels of the virus from someone that had the virus and has recovered, but still has low levels in their body, and that comes back as a positive test. That's not a knock against the test. It's a very, very sensitive test. But sometimes it's a little too sensitive on the back end of infection. It's definitely what you want early on, maybe even before somebody's developed any symptoms, to know that they've actually got virus in their body. But those are pretty much the gold standard of detection systems.
While we're on testing, can you share a little bit more about the rapid test and why PCR is preferred?
The rapid test is actually looking for the presence of proteins associated with the virus in your body. It's like the rapid flu test or the rapid strep test. Its strength is that it's fast, 15 minutes. It's less sensitive, and so it may miss lower levels of infection in your body. And early on, we were pointing people towards PCR, PCR, PCR. But at some point, you want to make the switch to, I have a test I can do from home that doesn't require me to go to a doctor or to a lab to use a specialized piece of equipment, but essentially lets me spit on a tube and then tell me if I'm likely infectious. Even if it's less sensitive, if it's something that I could do every day, I would increase the likelihood of catching those infections. And I think you're going to begin to see more of those rapid at-home tests come into the market. The challenge is they can't be $25 a test. It's got to be something that's really inexpensive so that you could have a set in your medicine cabinet. And so if you wake up and you've got a funky cough and your throat is really sore and you've got a low-grade fever, you can pull one of those out and you can see if there's with some degree of effectiveness, am I dealing with COVID or am I dealing with something else? One of the things, Cheryl, that I think we're going to see really begin to shift in the field is the idea of at-home diagnostic tests like these rapid tests. I know that physicians might have some anxiety around that, around people, diagnosing themselves from home, but being able to have that information at your fingertips, especially for people where it's difficult to get to the doctor or they don't have a relationship with a doctor. There's a place for that in our medical care as long as it's appropriately crafted and here's what you do after that. But I really think that the pandemic has opened up that door and it's going to be very difficult to say, nope, we're not going to be doing any at-home tests going forward.
And I'm sorry to Manuel, and I did message him that we don't have any specific information on Sinopharma vaccines, but it did lead to a question for the safer vaccines for individuals with disabilities or other immunology diseases, and since it's a killed vaccine. Do you have any thoughts on that?
There are a lot of, the killed vaccines are the vaccines. Those are the things we're more familiar with. That's what a historical vaccine looks like. These are different, the mRNA vaccines are different kinds of vaccines, but that doesn't mean that they're any less safe. They certainly come to market much more quickly. And there at the moment doesn't seem to be a difference in safety profile between an mRNA vaccine and a killed vaccine. I recognize that those are what we have a greater comfort with. That's what we're used to. We've seen more years of that testing, but there are some advantages to the mRNA vaccines in terms of the speed and the agility that you can bring something like that to market. That's just more difficult with a killed or a weakened vaccine.
And I did hear also early in vaccinations, a lot of resistance to mRNA, the unfamiliarity of the approach, even though it had been studied for 17 years and how fast it came to the market, and did it change your DNA permanently? Can you share a little bit for those that are concerned about our mRNA?
I got those questions a lot. Can the mRNA change my DNA? So the mRNA vaccine, the mRNA does not go into your nucleus where your DNA is kept. They do not interact. There is not a process where that takes place. That's not how they're designed. The mRNA is in your cells for a small number of days, and then it's degraded and broken down. You do not become transhuman. You do not become a genetically modified organism from an mRNA vaccine. But Cheryl, I think part of the challenge is these are technologies that you and I can't touch. I cannot see them. I can't witness them under a microscope. And so I have to take them on faith. I have to trust the scientist or the public health official that is telling me about this. And that's really difficult for us to do when we don't have a previous set of experiences and I can't physically touch and manipulate this thing that I'm being asked to trust. I understand why people have anxiety around those kinds of things.
And just a follow-up question real quick on those that had already had COVID and they are set now after a small waiting period. What period of time do you recommend before they go ahead and take their shot, since they do have a perceived 90 days or more immunity?
The data that I've seen actually now says, as long as you're no longer actively infectious and you don't have any symptoms, you could go on ahead and get vaccinated at any point after contracting COVID, with one really important exception. And that's if you were given monoclonal antibodies as part of your therapy. If you were given antibodies as part of your therapy, those are in your system for 60 to 90 days. and they can totally blunt the ability of the vaccine to do its job. So if you have had COVID-19 and were given monoclonal antibodies, you want to wait 2 to 3 months before you go in for your vaccine.
And then a lot of our clients are immobile and they already have concerns with pneumonia and respiratory issues. Do you have any advice for their care or vaccine protocols? As careful as we are, a lot of them are in group settings as well. So do you have any advice for those of us that serve individuals with disabilities that might have mobility and respiratory?
So I apologize, but we've now stepped outside my sphere of knowledge, and I would be hesitant to speak into that when so many other people on this call probably have so much more expertise around that than I do.
Okay, that's fine. Some had mentioned, shall I go ahead and get a pneumonia shot or something as a precursor to try to help? And so I wasn't sure if you had had any research on that. The other question from Emmanuel is, what advice for health professionals with CP, the doctors and the nurses themselves?
I'm wondering if this is because they're frontline workers, or so I'm not 100% certain where Emmanuel is going with that question. I think some of it also depends on the types of symptoms that an individual with CP might have. Continuing that protective personal equipment, doing those things. If getting vaccinated would be probably the first thing that I would say. And if you're unable to be vaccinated for whatever reason, then all of those things, masking and distancing and personal protective equipment, continue to become really, really important.
Okay, we have another question on, is the rate of clotting and low platelets side effect that is seen with the J&J vaccination comparable to that of the AstraZeneca vaccine, as both are viral vector vaccines?
That's a really perceptive question. They both are using viruses. They're viral vectors, as the questioner noted. There are a lot of similarities between what you see with the clotting with AstraZeneca and what you're seeing with Johnson & Johnson. And it is possible that they are actually caused by the same mechanism. But there are some other viral vector vaccines that are not necessarily seeing these same kind of results, these same kind of clotting factors. So it might be that it's a system-wide issue for that type of vaccine, but it might not be. I think we've got to gather some more data around that.
Okay, and Emmanuel did say he is a frontline worker with mild CP, and that's putting him, I'm sure, at more risk. But I guess taking the precautions of any healthcare worker is the answer. So Donald said, I have severe physical CP and got my second shot in April. All went well. He had the Pfizer. His mother read dead fetal cells. Is that a myth? Sorry, not meaning to worry anyone, but just curious.
So there is a story that circulates that the vaccines are made from fetal tissue, that the vaccines contain fetal cells from abortions. And I think that that's what Donald is talking about. And that is a myth. Vaccines do not contain fetal cells. They don't contain aborted fetuses. Now, here's where there's a grain of truth in lots of these stories. And here's the grain of truth in this. Many vaccines use what are called cell lines. So these are cells that are grown in labs, and those cells grown in labs make the components of the vaccine, the outer protein coat, the specific individual pieces of some of the vaccine. And some of those cell lines actually were originally from terminated abortions in the 70s and 80s. So 2 or 3 of these long-standing cell lines that are actually used in lots of medications, not just vaccine, but they're used to make lots of different medicines. A handful of these are cells that originally came from abortions in the 70s and 80s. That doesn't mean that the vaccine itself contains aborted tissue, and the mRNA vaccines did not use those cells. So there's a website I think it's the Charlotte Lozen Society. The Charlotte Lozen Society actually talks about which vaccines don't use fetal cells in their development and which ones do. And many faith groups have put out statements that have said, these vaccines are ethical, these vaccines should be used. This is not something that should be something that stops somebody from getting a vaccine.
Great, and we're coming, well, I have another question just popped up, but let's just ask James' question real quick. How can we make this a more tangible experience in order to get the correct information out to the individuals we serve and or anyone else without actual exposure, of course? So more tangible experience so that we can share the correct information.
Well, I think I see that you have streamed this on Facebook and that you've also recorded this. So Cheryl, I would imagine that you may be making this available for others to view down the road. That would be one way. The link to the videos is in the blog. The link to the blog is in the chat, pointing people to that as well. I think James, it's just having conversation and pointing people to trusted sources. I know that sounds very trite, and that's more complicated than let's just talk about it. But I think helping people separate myth and fear from fact is really important. And that requires listening, and that requires taking time and trying to dig into the right answers.
He agrees with you and he says, thank you. And now for our last question before a comment, can you help Joy understand how to respond to people who have concerns about people who get vaccinated impacting the health of others around them, their menstrual cycle, fertility, etc.? I have a hard time responding to this in a compassionate, data-based way without just saying that is impossible and not true, which I'm sure is not particularly effective.
Joy, you're right. Saying that it's impossible and not true is probably not going to be the most effective way to counter somebody's concerns. So you are on the right track with that. I generally acknowledge that this is something that I have seen a lot of. So there's a lot of information on social media about that the vaccines will make someone infertile or the vaccines will cause, miscarriages. So I acknowledge that I have seen these, that they are rampant. Then I say, let me point you to a trusted source. So fertility, let me take you to the website for the American Gynecologists and Obstetricians. And here's what they say about this. And let me take you to this group that actually can tell you how this myth came about and can separate out the person who the myth is ascribed to says that they are the head of research and development at Pfizer, when that's really not what they are. And so I try to break it down, and I use websites like Snopes, SNOPES. That's a great myth busting website. Many of groups like the New York Times or the Washington Post, USA Today have set up fact-checking sites around the vaccine. So I just try to take the time, either in writing or in person, to acknowledge what their concern is, because at the heart of that concern is the fear that if I get vaccinated, I'm not going to be able to have children. And that's a powerful fear. So let me just acknowledge that, but that's not what the science tells us. And if I pull apart the myth, and here's where it falls apart, particularly with the fertility one, if that were really happening, if the vaccines were causing fertility, the argument that they're using means that everyone who has ever been infected with COVID also would be infertile. And we know that that's not the case. So it takes time and teasing out what the issues are.
Well, thank you for that information. And the last comment, I just want to agree with James. Given 28% of the US population has a disability, I am very hopeful that this will become an ongoing metric regarding COVID. So this is a very large segment. Hopefully more data will become available. We appreciate you taking the extra time to research and find a little bit more disability specific information for us today. And before I turn it over, do you have any last comments or thoughts you would like to share?
I would just like to say thank you. You've asked great questions, everybody. It has been a real treat to spend this time with you. And Cheryl and Armando, thank you for allowing me to speak to your teams. Thank you for the work that you are doing. It is tireless. It has been incredibly challenging in the midst of the pandemic. But I know that you do it because you know how critical it is for the families that you serve. And I deeply appreciate that.
Well, we know how busy you are at this time. Thank you for sharing your time to help us better understand so we can better serve those that are clients of our center and their families and their caregivers. So thank you again. And now I'm pleased to turn the program back over to our UCP National President and CEO, Armando Contreras, for his final thoughts.
Thank you. Thank you, Dr. Lamb, for your presentation, and an honor for UCP to have you as our keynoter. I also want to thank you, Cheryl, for introducing Dr. Lamb to us and for the awesome job that you did facilitating this component of our annual 2021 annual meeting. As we close, I want to thank my entire team for the work they did on not one virtual event, but 3 virtual events in the past day and a half. So my deep gratitude to my team, as well as our sponsors, Mass Mutual, our premier sponsor, also Waymo, the New Motion Foundation, CARF International, and Architectural Resource Team. We couldn't have done this without you. I would be remiss if I also didn't thank the leaders, staff, and volunteers at UCP's 58 affiliates in the United States and Canada for their incredible efforts day in and day out, but especially for the unwavering dedication they've exhibited over the past years. Plus, by stepping up in countless ways, big and small, to support the individuals, families, and communities we serve. Your work on the front lines every day is not only deeply appreciated, but oftentimes it's nothing less than life-changing and life-saving. And last but not least, I want to thank you, our audience, for joining us and supporting the work of UCP. Thank you, and we look forward to seeing you again. Bye-bye.